Good afternoon. Thank you for joining our Debbie's Dream Foundation webinar series. Today's webinar is featuring Dr. Craig Lockhart. I'm Jackie Bello, Programs Manager for Debbie's Dream Foundation, and I'll be moderating today's webinar. I'd like to thank our sponsors, title sponsor Merck, platinum sponsor Astellas, and gold sponsor Bristol Myers Squibb. First, I will share information about stomach cancer and Debbie's Dream Foundation. Then we will hear a presentation with Dr. Lockhart. The presentation will be followed by a Q&A discussion. You can type your questions throughout the presentation into the chat section that appears on the webinar menu. We will address questions at the conclusion of the presentation as time allows. This year, nearly 30,000 Americans will be diagnosed with stomach cancer. Stomach cancer is the second leading cause of cancer deaths worldwide after lung cancer, with a dismal 5-year survival rate of between 20 to 30%, depending on the country. Many patients are asymptomatic during the early stages of stomach cancer, leading to a late diagnosis. Debbie's Dream Foundation is dedicated to raising awareness, advancing funding for stomach cancer research, and providing education and support internationally to patients, families, and caregivers. Our ultimate goal is to make the cure for stomach cancer a reality. You can learn more by visiting our website at debbiesdream.org. Pictured here is Debbie Zellman, the founder of Debbie's Dream Foundation. Debbie was diagnosed with stage 4 stomach cancer in April of 2008. She had no risk factors and only vague symptoms. At the time, she was told her chance of being alive in 5 years was only 4%. She endured harsh chemo regimens and targeted treatments and experienced many reoccurrences over 9.5 years. Unfortunately, Debbie passed away on December 23rd of 2017 at the age of 50 after a 9.5-year battle with cancer. She dedicated herself to helping others with stomach cancer by raising awareness and providing resources and education. Debbie founded DDF in April of 2009. As an organization, we will continue her important work and legacy. In a few short years, DDF has achieved many great milestones. We have 32 chapters across the US, including Canada and Germany. Our PrEP program helps patients, their families, and caregivers match with survivor and caregiver mentors using disease-specific criteria, including stage, biomarker, and location. We host educational webinars and symposia year-round, and our website contains in-depth information about stomach cancer. We have also provided $1 million in research grants to date. In addition to research funding, we also advocate at a national level. 2020 Capitol Hill Advocacy Day was a huge success. We hosted 115 advocates and had 230 meetings on the Hill, making it our largest and most successful turnout yet. Due to the efforts of the Foundation, our partners, and our dedicated advocates, we help secure continued funding for stomach cancer research. The peer-reviewed Cancer Research Program received funding from Congress in the amount of $110 million, a $20 million increase from last year. Please join us next month for our virtual advocacy day on February 11th. You can register at debbiesdream.org and let your voice be heard. Here you can see some of our upcoming events. To learn more, visit our website. DDF is headquartered in Plantation, Florida. Our office hours are Monday through Friday, 8:30 a.m. to 5 p.m. Eastern Time. Also on this slide are important phone numbers and email addresses you can use to contact our office and staff. We will now begin the presentation on perioperative chemotherapy with Dr. Lockhart. Dr. Lockhart is a professor of medicine and chief for the Division of Medical Oncology at the University of Miami-Sylvester Comprehensive Cancer Center. His primary academic mission centers on early clinical drug development in oncology with a focus on upper GI cancers. We'd like to thank Dr. Lockhart for taking time out of his schedule today. And now, Doctor, I will turn the presentation over to you.
Thank you for the kind introduction, Jackie, and thanks to the Foundation for inviting me to speak. And thanks for the audience for joining us this afternoon. As I mentioned, we're going to talk about perioperative treatments for patients with stomach cancers. Get the slides to advance. Okay, yes, we're going to talk about perioperative therapy, which is one of the approaches that you can use to treat patients with gastric cancers. But we'll talk a little about background, and I'll talk about some other approaches as well, but focus on perioperative therapy. So, as Jackie mentioned, these are the statistics for gastric cancers in 2020, in that depending on the stage that you're diagnosed, about 30% of patients live 5 years. As you can see, the majority of patients who are diagnosed have regional or distant metastatic disease at the time of diagnosis. So looking at their 5-year survival trends, you can see that the patients with distant disease or regional disease are less likely to do well at the 5-year mark. So it is helpful to have patients diagnosed at earlier stages. So again, you know, being very conscious of your symptoms and your family history are all very important things to try to identify patients at an earlier stage. These are the risk factors, the known risk factors for gastric cancers. The one I'll point out at the top is H. pylori infection, which tends to vary country by country. I'll have a slide on that. But again, there's some other potential risk factors here that are important. There are some genetic syndromes where gastric cancer is a portion of that, although it's a relatively small number. About 3% of the patients are part of that have an inherited risk. But again, these are the common risk factors that we have identified. So speaking specifically about H. pylori, colonization is a known cause of gastric cancer, and 2/3 of the world's population harbors this. It's more highly seen in developing countries, more so than in developed countries. Eradication is one way in reducing gastric cancer burden across the world, is that this seems to be a cost-effective way of actually reducing the burden of gastric cancer across the world, because it is an organism that can be eradicated. Other risk factors, including lifestyle and diet, there's an increased risk in current and ex-smokers. Dietary components such as consuming smoked foods and salted fish, etc., can be associated with higher risk. They believe that the nitrates and the nitrites in the foods prepared in this manner are converted by intestinal bacteria into carcinogens, again increasing the risk. As you can see in Korea, the risk of gastric cancer is highest among countries. In more Western countries, including the United States, obesity tends to have a larger role in the development of gastric cancer, and those gastric cancers tend to be a little bit more proximal, a little bit of the higher up in the stomach gastric cancer. There are two main pathology types that when we get a diagnosis that the pathologist identifies to us. I'll spend a little bit more time talking about the diffuse ones more than the intestinal type for some specific reasons. But quite often on a pathology report, they'll say this is intestinal type or diffuse type gastric cancer when you get the pathology report back after an endoscopic biopsy. Okay, typically when somebody is having symptoms and they go to see their doctor, one of the tests that can be done often is a barium swallow, although we don't see that quite often these days. Most people now get referred for an endoscopy. If a mass is seen on the endoscopy or something that's suspicious is seen on the endoscopy and a biopsy is performed, usually there's a CT scan performed next, usually to include the chest, abdomen, and pelvis, as this would account for the major places where gastric cancer is thought to spread. Another common evaluation, if somebody does not have metastatic disease or stage 4 disease, is to do an endoscopic ultrasound to give us an idea about the size of the tumor and how extensive the tumor is into the lymph nodes. Often a PET scan is also ordered. Sometimes insurance will pay for that, sometimes not. But a PET scan is a very common thing to be ordered. And then the last one, the diagnostic laparoscopy. I don't see this performed as often as it should be. It is part of the standard evaluation for patients with gastric cancer, but it's not always performed everywhere. this is where my point with the diffuse gastric cancers is concerned. If somebody's diagnosed with a diffuse gastric cancer, quite often the scans, such as a CT scan or even the PET scans, can underestimate the amount of cancer that we're actually dealing with. Therefore, the diagnostic laparoscopy is very important to give us an idea of the extent of the cancer. Because sometimes what will look like localized cancer based on endoscopy, based on a CT scan, even based on a PET scan, can be more extensive when the diagnostic laparoscopy is performed. And the ones that tend to fool us that way tend to be the diffuse gastric cancer types. So if somebody's diagnosed with a diffuse type, I would strongly emphasize that a diagnostic laparoscopy should be performed. It should be performed anyway as part of the standard evaluation, but in diffuse types, definitely insist upon that. All right. So now this is my typical approach to patients with gastric cancers. If somebody has a relatively early stage small gastric cancer, recommend is go ahead and have surgery. If the tumor is a little bit larger, more locally advanced, which I'll talk a little bit about in a minute, then we are looking at different approaches. What we're going to focus on today is the perioperative approach, perioperative chemotherapy, which is one of the standard of care options to treat this particular kind of cancer. In stage 4 cancers, we're looking at primarily at chemotherapy as our primary modality of treatment. Okay, so before we get into the perioperative approach, we'll talk about adjuvant therapy. And all adjuvant therapy means is treatment that we give after the surgery to reduce the chances of the cancer coming back. So in this scenario, we do the curative intervention first. Chemotherapy, radiation therapy are not curative modalities. Surgery is the only way to cure gastric cancer regularly. Have I had some patients cured with chemotherapy? Absolutely. But it is not the norm. It would not be the expected outcome. So surgery is the curative intervention. And so doing adjuvant therapy, patients have surgery first. And then what you're aiming to do with the adjuvant therapy is eradicate any micrometastatic disease that may be in the body. And how you read out whether we're improving things or not is looking at relapse-free or progression-free survival and overall survival. Now, the downsides of adjuvant therapy are there can be side effects from chemotherapy. Generally, after surgery treatments are more poorly tolerated than before surgery treatments, which is some of the rationale for perioperative therapy, which I'll come back to. And then sometimes, depending if the recovery from surgery is slow, there can be a delay in initiation. The sweet spot of starting chemotherapy after surgery is somewhere in the 6 to 12-week range. Generally, I try for 6 to 8 in my patients. But after about 12 weeks or 3 months, a lot of people will just pass on doing adjuvant therapy because we're not sure that the benefit is there after that period of time. And so if somebody has a complicated surgery or complicated recovery from surgery, there can be delays in starting the adjuvant therapy. The study that showed us that adjuvant therapy was meaningful is what we call the Intergroup 0116 study. And in this particular study, again, we're going to focus on perioperative here, but this is just adjuvant. These patients had gastric cancers, they had surgery, and they were then randomized to observation or receiving chemotherapy and radiation therapy afterwards. A certain kind of surgery, a D2 resection, was recommended, which is now the standard, but at the time it was not. And so these patients some of the patients received chemotherapy and radiation therapy based on randomization. And what we found was the patients who received chemotherapy and radiation therapy after surgery were less likely to relapse. Also, those patients had better survival overall. Their 5-year survival was improved. And so this initially became the way that we treated patients with gastric cancers. Surgery first, and then afterwards, chemotherapy and radiation therapy. So this was the established way of doing things. It had established benefit. It prolonged relapse-free survival by 52%, overall survival by 35%. I mentioned, and this will become more important a little bit later on, I mentioned that in that study, they recommended a D2 resection, which is and I'll have a slide on that as well. Only 10% of the patients had a D2 resection in that study. The majority of patients had a D0 resection, which would now be considered substandard surgery for modern times. It is not, that's not, you should not be doing a D0 resection anymore. And so a lot of surgeons have always said that the reason why the radiation was important in this study was because the surgery was not optimal. And so subsequent studies with better surgery are going to have been performed since then. So before we get into some additional discussion about the optimal type of treatment, chemotherapy and radiation therapy, or chemotherapy around surgery, let's talk a little bit about surgery. And the main question that a lot of my patients have is, when they're diagnosed with stomach cancer, is, are they going to have to remove my entire stomach? In general, and this is not, I can't say 100% of the time, in general, if somebody has a stomach cancer that involves the upper part of the stomach, the cardia or the fundus, then the patient's likely going to need to have a complete gastrectomy. If they have a more distal gastric cancer involving the antrum or the pylorus, then quite often they can do a partial gastrectomy and save some of the stomach. And that's important. As I said, that is almost the key question almost all my patients ask me after an initial diagnosis: am I going to have my entire stomach removed? Okay. I spoke a little bit about a D1 versus D2 resection. And all it means is the number of lymph nodes that are removed at the time of surgery. D1 resection removes, a smaller number of lymph nodes. A D2 resection removes more lymph nodes. And now in certain Asian countries, they're doing D3 resection. But what happens with a D2 resection is that you remove more lymph nodes. If those lymph nodes have cancer in them, you get better staging, assessment. So you have a better idea of what stage cancer the patient's cancer is after surgery. And more recently, we have studies now showing that patients who have had a D2 resection are more likely to live longer and have fewer complications related to their gastric cancer. These are the D1 resection patients here. These are the D2 resection patients here. These are the D1 resection patients here. And so a D2 resection is the standard operation now. As I mentioned in the prior study, the Intergroup study, very few patients actually had a D2 resection. Now, into this milieu, we have the classic trial. This study was done in Asia, and 100% of the patients had a D2 resection. So if you recall from the Intergroup study, only 10% had a D2 resection, and so people have often said that the reason why radiation was required is because the surgery was not adequate. Now, in this current study, the classic study, 100% of the patients had a D2 resection. So in this study, they randomized patients between observation after surgery or chemotherapy. While all the results are not fully available on this study because they have to follow patients long term, what they were looking at was disease-free survival or relapse-free survival. And what they showed was that the patients who received chemotherapy after surgery did better than the patients who just were randomized to observation. And these patients had D2 surgeries, which is now the standard way that we should be doing surgery on these patients. So to conclude, if there's a D2 resection, there's no need for radiation therapy. Chemotherapy is sufficient. With surgery only, the 3-year relapse rate was about 59%, and with chemotherapy plus surgery, 74% of patients did not have relapse at 3 years. Therefore, if somebody has had a D2 resection, then chemotherapy should be the standard of care. No radiation is needed. If they have less than a D2 resection, say a D0, hopefully not, or a D1, then chemotherapy and radiation therapy is the likely recommendation. Okay, now to get to our main topic here. So why would we do perioperative chemotherapy? As I highlighted before, sometimes there's a delay after surgery because someone's having a recovery. A gastrectomy is a big surgery, a really difficult surgery to recover from. So it's important and we think it's important that patients get this additional treatment, whether it's, assuming it's chemotherapy, but we think it's really important that they do that. So if we give the chemotherapy up front, can we eliminate that micrometastatic disease at diagnosis rather than waiting until after surgery? So the potential benefits for doing chemotherapy up front are to downstage the tumor, make it smaller so that surgery is that much easier. And then also, as I said, eradication of any possible metastatic cells that might be circulating around that we can't detect by imaging, but cells that might be circulating. The risks are there's some suggestion that by giving chemotherapy up front, that if the cancer should recur or something along those lines, those cells that recur will be resistant to chemotherapy. That has not necessarily been proven to be the case. You are potentially delaying surgery. As I mentioned, surgery is the curative component of what we're trying to accomplish here. And you're potentially delaying the surgery to do chemotherapy. The chemotherapy is not perfect. The response rate of the chemotherapy is only about 50% overall. And so some patients, or some percentage of patients, won't respond to the chemotherapy, so you're potentially delaying their therapy. And another downside to the perioperative approach is that a lot of patients afterwards can't receive the chemotherapy because they still haven't recovered from their surgery, just like we talked about in the adjuvant setting. So the first study that received sort of wide discussion was the MAGIC study for perioperative chemotherapy. In this study, patients were randomized between receiving chemotherapy with something called ECF, which is epirubicin, cisplatin, and 5-FU. They received 3 cycles of that, followed by surgery, then 3 additional cycles of ECF. Or if the patients that weren't in the ECF arm, they then received surgery alone. And this study was published back in 2006. It was called the MAGIC study. Now, using this approach of perioperative chemotherapy, these patients did better. There was an improvement in the patients' progression-free survival and overall survival in the patients who received perioperative chemotherapy as opposed to surgery alone. When we talk about the local recurrence at the bottom of the slide here, the patients who received the chemotherapy were less likely to have recurrent disease that occurred near the surgery site, and they were also less likely to develop metastatic disease. So this was a successful study. This is a study that showed us that perioperative treatment for appropriate patients with stomach cancer was the right way to go. However, the problems with the MAGIC study was that the ECF regimen is relatively toxic. So there was also a question about whether epirubicin was actually offering anything. Epirubicin in other studies was shown not to be that beneficial. So they wanted to try a different regimen. So the regimen they used this time was Flot, F-L-O-T, which stands for 5-FU leucovorin, which part of our standard, oxaliplatin, which substituted for the cisplatin, and then the new drug in this regimen was Taxotere. So Flot was the regimen for the Flot 4 study, and the comparator arm was what I just discussed, the MAGIC regimen. The regimen from the MAGIC study was epirubicin, cisplatin, 5-FU. So it was Flot versus ECF in the Flot 4 study, and again, these were patients who had gastric cancers, cancers of the gastroesophageal junction, and some esophageal cancer. Almost 25% of the patients in this study had esophageal cancers. When you looked at the relapse-free or progression-free survival, and this is not showing up as well as I would like, but the patients who received the new Flot regimen did better than the patients that received the MAGIC regimen. Again, the numbers are not projecting that well here, but again, with the MAGIC regimen, relapse-free survival is about 18 months, and with the Flot regimen, it was 30 months. And if you're looking at 2-year relapse-free survival, it's 43% for MAGIC and 53% for Flot. And some of these other projected 31% for MAGIC, 41% for Flot. This is relapse-free survival or progression-free survival. If you look at overall survival, the numbers were again similar. That the median overall survival for patients receiving the MAGIC regimen was 35 months versus 50 months for patients receiving Flot. And similarly with the 2-year, 3-year, and projected 5-year survival, you're seeing that the patients who received Flot did better than the patients who received the magic regimen. So Flot with 4 treatments before surgery, then 4 treatments after surgery is now the standard of care. That's a standard way that we treat gastric cancer patients with certain stages of disease. So where are we now? So perioperative Flot, as I just mentioned, based on the Flot 4 study, is the standard of care. That's what we do. The issues with Flot is that only about 50% of the patients actually complete the adjuvant therapy. In the Flot study, after surgery, only 60% of the patients who had surgery were able to even start the chemotherapy after surgery, and only about 40% actually finished all 4 of the post-operative treatments. So because of that, there is some question about whether should we be doing all of the chemotherapy up front. Instead of doing 4 before surgery, then 4 after, should we do all 8 in front of surgery, because giving the chemotherapy after surgery is somewhat challenging. But again, another downside thing is, as I mentioned, only about half the patients actually have their tumor shrink with the preoperative chemotherapy. So, you don't really want to give 8 cycles of chemotherapy to somebody when their tumor is potentially resistant already to that particular treatment. And then also we need to figure out a way to incorporate newer agents, things immunotherapy, targeted therapy. We need to figure out a way to incorporate those into this, because in other diseases, I'll talk about esophageal cancer for a second. Immunotherapy seems to be helpful in the post-operative setting. There's a recent study that patients with esophageal cancer who received chemotherapy and radiation therapy, then surgery, giving immunotherapy after that, reduced the likelihood of the cancer recurring. And so should we do something along those lines in stomach cancer as well? As I mentioned, we are now, this is how our field is advancing. Some of the 5FU that we still use in our chemotherapy regimen has been around since the 1960s. I believe it was approved in something like 1967, and we're still using it. In the 1990s, the platinum agents, some of them were approved then, and some of the taxanes, like Taxol, paclitaxel, was approved back in the 1990s. When I was a trainee, oxaliplatin and irinotecan, gemcitabine we don't use a lot, but and docetaxel sort of came into use, and in the 2000s when we started seeing drugs targeting HER2 and drugs targeting angiogenesis. But now we're clearly in the realm of immunotherapy. So to try to optimize perioperative chemotherapy, these are some of the approaches that are ongoing. As I mentioned, we have to try to address these different problems with perioperative chemotherapy. As I noted, there are poor rates of treatment completion, that only about half the patients, sometimes less, of the patients actually complete the post-operative treatment. Because of that, there's something called TNT, or total neoadjuvant therapy. Instead of doing, as I mentioned, instead of doing the 4 treatments, 4 before, 4 after surgery, we do all 8 up front. And maybe that's the way to go. But we need to figure out a way to determine whether the tumors are actually responding before committing someone to essentially 8 rounds of chemotherapy that may not be working. There's also an effort to look at less toxic regimens, maybe eliminating the taxotere or eliminating one of the other agents so that the regimen is less toxic but potentially equally effective. And so there are ways to look at that as well. As I mentioned, some patients are not responding to this neoadjuvant chemotherapy, so you can potentially collect circulating tumor DNA. Sometimes this can give us an idea about whether the therapy is working or not. These things are being investigated. And then also interval imaging. There are some efforts underway to potentially incorporate PET scanning earlier in the course to see whether a patient is actually responding to the treatment or not. So we have to figure these things out. These are things that are ongoing. And then again, novel therapy. There's a lot of effort ongoing right now incorporating immunotherapy into some of these perioperative regimens to see if we can improve upon these outcomes. One proposed study that was proposed by my group actually was, instead of using Flot, to use FOLFIRINOX. Our hypothesis was that FOLFIRINOX is better tolerated than Flot. There's some debate about that because FOLFIRINOX is intense in itself. And then we're going to incorporate ctDNA, the circulating tumor DNA collection, at baseline and then every 2 cycles to see if the circulating tumor DNA is actually decreasing, which could be an indication that the tumors are actually responding. If somebody was not having a decrease in their circulating tumor DNA, it could indicate that either the Flot or the FOLFIRINOX was not working and that we need to come up with a different strategy. Again, this is one that's proposed. There are several studies that on these various committees that I serve, there are several studies that are ongoing that are attempting to address this particular concern that we have with the perioperative approach to gastric cancer. So this is how I go about things now. If a patient comes to me in my clinic and based on staging, they seem to have a T2 tumor or greater, then I'll consider perioperative Flot, unless we have a clinical trial. Clinical trials are always the default. Even if they have a T1 tumor, a very small tumor, but they have a lymph node that looks like it's engaged with cancer, I'm going to recommend that we do perioperative chemotherapy. So this is the current standard. T2 or greater, and any lymph, it doesn't matter what size the tumor is, but if the lymph node is positive, then we're going to recommend perioperative Flot chemotherapy. If the patient shows up to my clinic and they've already had surgery, so they were evaluated somewhere, it looks like it was a small tumor, the surgeon did surgery on it, did their partial gastrectomy or gastrectomy, and then it turns out that the tumor was at a higher stage than they anticipated, then we're going to have to look at the kind of surgery the patient had. If the patient had a D2 resection, which is the current standard, the patient had a D2 resection, then I think we can just do chemotherapy to reduce the likelihood of the cancer coming back. If the patient had less than a D2 surgery, a D1 or a D, hopefully not a D0, but had a D1 surgery, then I think that chemotherapy and radiation therapy would be the preferred approach in a patient like that. But as I mentioned, if usually now cancer care involves a multidisciplinary team where somebody's diagnosed and they consult with a surgeon, they consult with a radiation oncologist, they consult with a medical oncologist, and we kind of go through things together and decide on the best course of action. And as I mentioned, if they come to us beforehand, usually it's a perioperative chemotherapy approach like we talked about today. If they already had surgery, then we're looking at these other approaches for adjuvant treatment. So to conclude, curative gastric cancer therapies are well established. However, the clinical outcomes could improve. We still need to do better as far as how often we cure these patients. As I mentioned, there's still problems with the perioperative approach in that not all the patients are able to tolerate the after surgery treatments. And if we give all of it up front, we don't know that it's working. And so those are questions that we're trying to address with a variety of different ways of looking at this problem. Immunotherapies and targeted therapies are being investigated. There are studies that are in the planning stages and some that are ongoing to try to improve, to try to add immunotherapy or targeted therapy to some of these perioperative chemotherapy regimens to see if we can improve upon the outcomes. Again, there's tantalizing data from esophageal cancers, at least, that show that maybe immunotherapy could be helpful in this situation, but again, that has not been proven in this particular malignancy. As I mentioned earlier, we need to optimize the actual treatments to improve the tolerability and the efficacy, and those studies are ongoing. As I mentioned, one proposal with the FOLFIRINOX, so we think FOLFIRINOX may be better than Flot, but again, has yet to be proven. And as I mentioned, novel strategies and clinical trial participation remain the priority. Clinical trials, if a patient is seeking care, a clinical trial should be where should be our first thought. Can we enroll this patient in a study? Is there a study that's addressing this particular patient's concerns? And that concludes our presentation. What I would like to, sorry, we'll go back to one slide. What I would like to also highlight is on Monday evening at 8, there is a stomach cancer awareness network is having a support event for patients with stage 4 cancers. If somebody wishes to register for that, to participate in the support event, that's the website that you can register for that event. Again, this is for a support event for patients with stage 4 stomach cancer. Okay, available for questions.
Wonderful. Thank you so much, Dr. Lockhart. We do have some questions that come through. The first one is, why is D3 resection not typical in the States?
Okay. So, and this goes back a little bit to the D2. So when D2 resections were first recommended by surgeons in Asia, and it was first adopted in the United States, the outcomes with D2 surgery were not that great, in that the surgeons were doing D2 resections, but there was so much morbidity associated with the particular surgery that the patients weren't dying of the cancer, they were having trouble and dying from the surgery. Now that the surgery has become, the D2 surgery has become more standard, now there's moving on to the D3. And so the D3 seems to be more standard in Asia, but our surgeons in the United States and other Western countries have to become more familiar with the D3 approach, and then there'll have to be some evaluation of incorporating D3 surgery into our treatment plans, and then monitoring to see what the outcomes are. Because if the outcomes are not any better than a D2, then there's no point in doing that if it's just causing more potential perioperative complications. But we don't know that at this point. I would say that I've had colleagues who have gone to Japan and spent 6 months in Japan learning to do the surgery there, so that they're trying to utilize those techniques when they come back to the United States. But we haven't, that approach has not been tested in a Western population to this point, and to show that it's safe and effective in sort of US surgeons' hands.
Okay, thank you. The next question is, how often are the standards of care updated?
So on the, as a former member of the NCCN guidelines committee, we used to meet we have official meetings every 6 months, but whenever the data would come out, there'd be additional changes as well. So at least for GI cancers, the 2 big meetings we have are ASCO in June, and then the ASCO GI Symposium in January. And so those tend to be the 2 sort of big US meetings. There's also ESMO, which also occurs in the summer, and there's also an ESMO GI, which I believe is in the fall. And so those are times when new data is coming out. So the NCCN guidelines are updated. Usually we used to have a big update annually, but there'd be sort of smaller updates about every 6 months or so. But now the guidelines seem to be in a constant state of update. But when new data comes out that is compelling and meets certain standards, worthy of getting onto the NCCN guidelines. So it's a sort of a constant work in progress. But I would say at least every 6 months we do have a rigorous overview of the guidelines to make sure that the guidelines are in keeping with the research that's ongoing.
Okay, thank you. Another question. After surgery, my wife is having bad side effects from Flot, constant diarrhea. How long does this last, and what can we do to help?
So sort of figuring out that the cause of the diarrhea is an important thing. Some people can have diarrhea just from the surgery, from the kind of surgery that they've had. You don't have the same sort of storage capacity in the stomach, depending on the kind of surgery that they've done. So some patients just eating a regular diet and having no chemotherapy will have diarrhea after that kind of surgery. So that's something that's the first thing I try to tease out is this a post-operative issue related to just being able to store food or having the food go straight through, or is it something actually related to the chemotherapy? Of the chemotherapy agents, the F and the L, the full and the Flot, are the ones that are most likely to cause the diarrhea. If she didn't have the diarrhea before surgery, it's a little bit different to have it after surgery. Then that's when you start saying, okay, maybe some combination of the surgery and the chemotherapy contributing together. As I said, I don't know whether she had the diarrhea beforehand. Quite often, we try to have dietary interventions. Sometimes we have people take Imodium, just basically take 1 or 2 Imodium a day to try to slow things down. Chemotherapy can cause Clostridium difficile infections. You can have C. diff infections from chemotherapy. It's not just antibiotics. And so that's something else that would have to be ruled out. So there are lots of different factors, and we try to go through this in a thoughtful way, whether it's simply from the surgery? Is it from the chemotherapy? Or is the chemotherapy causing some other secondary problem, again, such as something like C. diff colitis that needs to be addressed before all this can happen? But sometimes if we can't find any other reason for it, sometimes we'll say, okay, let's just try giving somebody Imodium so that they can at least not have everything just running right through them all day long.
And after surgery, are they connected with a nutritionist as part of the team?
Typically,
Typically?
typically when patients show up into our clinic with any kind of GI cancer, it's, you meet with, obviously they meet with the surgeons and the medical oncologists, but they also are hooked up with the nutritionist, and depending on what's going on with them, also usually social worker, nutrition are very common parts of the initial assessment.
Okay, great. Another question related to dehydration. Hard to stay hydrated after chemo, haven't had surgery. What does work for your patients?
My nurse practitioner who works with me is very strong about patient self-advocacy. So she's always coaching them up on pushing and pushing and pushing with trying to keep oral fluids. The two ways that have helped my patients have been, besides my nurse practitioner Tracy doing that, the other has been increasing the amount of IV fluids that people receive with the chemotherapy. Also, sometimes the Flot is given every other week, and so sometimes on the week in between, coming in and getting IV fluids as well. Another approach that our patients tend to like is there's a version of the pump that patients go home with the 5FU. There's a version of that that you can actually go home with IV fluids, because it's a little bit more sort of similar to it's a little more physiologic to have fluids going in over a period of time. So he sent patients home with a pump and with fluids that they take home and they wear for 24 hours or 48 hours to try to keep themselves hydrated. If we cannot figure out a way that this person can stay hydrated by mouth, we've done the CAD pump, where they'll get a CAD pump once a week or twice a week or something along those lines, where they actually get the pump and they're home. Unfortunately, it's a little bit of a burden to walk around with a pump, but you have the pump on at home, for 24 or 48 hours. Those approaches have been successful with us as far as the hydration is concerned.
I agree with her. I think you have to be your own advocate and push and ask questions. I think it's really important. One of our patients, a lot of our patients actually say they always keep a journal, their symptoms, and just keep track of it, because you're going through a lot. It's very overwhelming. It's good to kind of have everything marked down, so when you meet with your oncologist or your team, you can kind of go through what the symptoms have been and what's worked and what hasn't.
I would go back to the patient who was having diarrhea after the gastric cancer surgery, and that's not uncommon at all. I strongly suggest that people have a food diary after surgery, because there are things that you can write down your meal. Okay, I ate, I don't know, chicken broth, no diarrhea. Okay, a donut, diarrhea, whatever, so that because eventually some patterns will emerge that you'll know what is potentially triggering this, or at least you'll at least identify a few patterns. Now, just because something causes diarrhea, 6 weeks after surgery, doesn't mean it's going to cause diarrhea 6 months after surgery. Things adjust and adapt in there. And so, but it's very important, as Jackie is saying, to have to keep a food diary, so to see if you're going to notice any patterns. Okay, I need to avoid those foods for at least for the next few months, to see if I can avoid the diarrhea and actually gain some weight and get my nutrition back to close where it should be.
Okay, next question. Effectiveness of systemic chemo for GLP with peritoneal metastasis, PCI is 20. Recommended regime, IP variable alternative.
Okay, so the question again. There's a lot of I have to.
A lot of information.
Lots of abbreviations in there. Okay, so
effectiveness of systematic chemo for GLP with peritoneal metastasis.
Okay.
PCI is equal to 20.
All right.
Recommended, what's recommended? IP viable alternative?
Yeah, that's a tough one. The Based on the PCI score, IP chemotherapy is actually more or less effective depending on the PCI score. There are lots of studies ongoing. There's, and I'm blanking on his name now. I want to say Bagwell or something Bagwell. There's a physician at MD Anderson. It's Doug Bagwell. I know he does a lot of these perioperative studies in gastric cancers. There's good data for certain kinds of cancers doing the intraperitoneal chemotherapy and systemic chemotherapy. There's good data, and there's some decent data for colorectal, obviously for appendiceal, even for ovarian. For gastric, the data has been somewhat underwhelming in that we don't think that the intraperitoneal chemotherapy approach is necessarily that successful. Now, there are ongoing studies to look at that and find out the best PCI score and what the best IP regimen is, what matches best with the best systemic regimen. I honestly don't know the answer to the question right now. I know those are things that are always under investigation about what we're trying to determine what's the best way. Right now, the data for IP chemotherapy and gastric cancer is not great. It's not that standard outside of a clinical trial.
Okay, thank you. Another question. I know hair loss from chemo is not permanent. Can any of the other side effects like neuropathy become permanent?
The neuropathy definitely can become permanent. The neuropathy from the oxaliplatin and the neuropathy from Taxotere in the perioperative, like in the regimen that we talked about, can be permanent. They can also improve over time. At least when the original oxaliplatin clinical trials years ago, after 6 months, about 70% of patients had some improvement in the neuropathy, not necessarily resolution, but some improvement in the neuropathy after 6 months. After a year, I think it was something like 80% or something along those lines, had an improvement after a year. But again, you're looking at 6 months and a year timelines for an improvement in the neuropathy. In some patients, it's permanent. Some patients, it never gets better. Once you've been off of neurotoxic treatment for a period of time, and your neuropathy has not been getting better, it is possible that it could be permanent. There are medications that can help to mitigate some of the symptoms related to neuropathy. Right now, I'm not aware of a medication that reverses neuropathy, but there are some that, if the neuropathy is painful or it causes a certain degree of discomfort, and it's going to be annoying no matter what. But if it's causing a certain degree of discomfort, there are medications that can help with the perception of that discomfort. Some are antidepressants and some are these nerve agents, the Lyrica, gabapentin, those types of things. But Cymbalta has been used as well in that setting. So again, it's more changing the perception of the neuropathy rather than actually reversing neuropathy.
Okay, great. The next question. I have my first round of chemo next week. I'm nervous. What should I expect?
Okay. Again, somewhat depending on the chemotherapy. If it's Flot, like what we've been spending our time with here, I would expect fatigue. The fatigue is everybody gets that. I know very few patients who have gotten through without the fatigue. The fatigue with Flot or with FOLFOX or something like that tends to start a day or two after the chemotherapy. I would expect your first day to be okay. Most people, they go in there, they're nervous as heck and more anxiety. You're more anxious than anything else. That's probably the main side effect of the first treatments would be anxiety related to what am I getting into here, what's going to happen. But usually the first day for most people is okay. Even the second day, people may feel some sort of fatigue and some queasiness maybe the second day. But usually for most of my patients, the third day or chemo's on Monday, Wednesday is when a lot of the side effects tend to hit, and it's mostly the fatigue that I can almost guarantee the fatigue is going to happen. With those regimens that we commonly use in this setting, fatigue lasts somewhere between 2 and 4 days for most patients. So again, chemo on Monday, fatigue on Wednesday, Thursday, Friday, possibly Saturday. Hopefully by Sunday you start feeling a little bit better again. So I almost promise you fatigue. Depending on the regimen, nausea can happen as well. Nausea tends to start the day after. Again, you're loaded up with antiemetics during the infusion, so that tends not to be that bad. It's the day after that some of the nausea can happen, day 2 and the Wednesday or so. The nausea tends to, in my experience, tends to be the most intense, maybe then and maybe the day after, maybe Wednesday, Thursday, those kind of. You should have medicines to prevent that, or at least medicines that are provided for you as needed. Some people take the as needed medications for 2 or 3 days, sort of, every 8 hours, every 6 hours to try to prevent anything from happening. But I can promise you fatigue, nausea, 60-40. Cold sensitivity, again, depending on which medicine you get, if it's the oxaliplatin, cold sensitivity, about 70% of patients get cold sensitivity, where touching things that are cold or even walking barefoot on the floor, less of a problem in Florida, but walking barefoot on the floor can feel like this electrical sensation. Drinking things that are cold, sore throat, sometimes pain with swallowing, tight jaw, those kinds of things that can happen with the cold sensitivity, and low blood counts. That one you may not be able to detect sort of physically on your own, but your doctor, your physician team, your medical team will be very aware of monitoring your blood counts as part of the regimens, so that if normally you get chemotherapy, your counts go down, they bounce back in time for the next treatment. If that's not happening, to keep you on a regular schedule, they'll likely institute growth factor injections, sometimes from the beginning, but they'll likely institute growth factor injections to try to keep you on a regular schedule.
Okay, thank you. Next question. Is recommended to do a partial gastrectomy. Can I push for a full, and will it be covered by insurance?
Why would you push for a full? I don't, that's a very that's a strong self-advocate person right there. But anyway, I would put some faith in the surgeons about that they know what they're doing, and why they probably have their particular reasons for wanting to do one versus the other. The nutritional, I'm trying to think of the right way to say this. Your nutritional recovery after a partial is better than a total. It's not better is the wrong word. It's more efficient, that you're quicker able to get back to where you think you should be nutritionally and eating, and than with a partial versus a total. Either way, you're going to have to, eating is something you take for granted. I mean, we all, we're eating before we have conscious memory. And so relearning what to eat and how much you can eat and those kind of things are all going to be part of the recovery process after a surgery like this. It's that relearning process is a heck of a lot easier after a partial gastrectomy than a complete gastrectomy. So I try to put some faith in the surgeons that they know what they're doing, and that you trust in their recommendations. If you wanted a second opinion, I would seek a second opinion if you're
Absolutely.
have concerns about that.
Wonderful. Thank you. Unfortunately, we are out of time for more questions. Dr. Lockhart, thank you so much for joining us and sharing your expertise. We appreciate it.
All right. Thank you for having me, and everyone stay safe and get your vaccination.
Yes. I'd like to thank our sponsors again, title sponsor Merck, platinum sponsor Astellas, gold sponsor Bristol Myers Squibb. To view any of our recorded webinars, please visit our lecture library. This concludes today's presentation. Thank you so much for tuning in. Have a great one, everyone.